Hi everybody, I'm Tori.
Olivia. I'm Joe.
Kaitlyn. We're going to be focusing on interventions for Alzheimer's disease today. I'm first going to define it. So Alzheimer's disease is defined as a progressive disorder that primarily affects memory, cognition, and behavior. I provided a few statistics that are relevant that kind of back up our research and why it's so important. So the current estimated prevalence in the United States is 6.2 million people, and by 2050, 12.7 million people will be diagnosed. And in Indiana specifically, it's estimated to increase by 18.2% by 2050. Non-pharmacological treatments such as occupational therapy and what we'll be focusing on today are going to focus on maintaining cognition, improving overall quality of life, and increasing independence in occupations such as IADLs and ADLs, leisure, and sleep. So the base of our research was focused on the systematic review by Smallfield and his colleagues, and they identified 5 different themes of intervention, and that's occupation-based, sleep, cognitive, physical exercise, and multi-component interventions. And the ones that we're going to focus on today, just based on time, because there is so much information available, is occupation-based, cognitive, and physical exercise. It's also important to mention that there's 3 different stages of Alzheimer's disease. In the early stages, Alzheimer's symptoms are mild and characterized by general forgetfulness. This also can be passed off by family members as just getting older and isn't recognized as early. And in the middle stage, the symptoms are more disabling and additional care will be needed. And then the late symptoms, they're very significant and apparent and usually have to be placed in assisted living or skilled nursing facility.
So I focused on occupation-based practice. I'm sure everybody is pretty familiar with it. It's our unique sort of approach, using occupation as both a means and an end. And while all occupations are obviously essential for people diagnosed with AD, I sort of focused on the most widely utilized and researched interventions, occupational interventions, ADLs, IADLs, leisure, and social participation. So as Tori sort of mentioned, it's definitely a progressive disease, and that progressively impacts your ADLs. The research out there available on ADL interventions was largely focused on self-feeding, grooming, and functional mobility. They use strategies like specific cueing, which sort of use simple and direct language, as opposed to more complex sentences that are kind of going to go over their heads or get lost in the middle. Compensatory strategies, and these were very client-centered and client-focused to meet their individual needs. And then errorless learning techniques, which provided immediate prompting and feedback throughout the activity. So the outcomes were all generally positive, improved participation. Notably, they reduced agitation and they improved communication with caregivers as these caregivers kind of developed the skills to better meet their needs and understand what they were wanting. There was little research conducted on the other remaining ADL occupations, toileting, bathing, and sexual activity. And again, client-centeredness was heavily focused on and emphasized in the research, and it really showed to improve participation and outcomes. So with IADLs, they're generally the first to decline with AD, as they generally require more executive functioning skills and more complex tasks. Some of the methods are similar. Verbal prompts, again, very simple, direct words, and then environmental modifications and training. And again, those are similar to ADLs. There were also reality orientation and cognitive simulation methods used. This kind of one study included money management, facial recognition, word games, things like orientation, daily orientation, and they were all sort of accompanied by multisensory stimulation. And the outcomes, again, were generally positive, improving quality of life and improving IADL performance. And this 2003 study I included as a great example of IADL interventions. They hosted a community cooking class for people diagnosed with dementia. And the results really improved mental health, and then also they decreased agitation. So as Alzheimer's disease progresses, there's a noticeable impact on speech. And they often also experience loneliness and depression sort of as a result of this. But research found that structured conversation provided the best outcomes for people who maintain their speech. And many of the interventions, the social interventions, used family involvement, caregiver communication, games, and then they also involved other occupations like ADLs, IADLs, leisure, and group discussion. But a 2011 systematic review showed that no one intervention approach was more effective than the other. The outcomes did end up reducing that loneliness and depression that I mentioned earlier, improved quality of life. But there was a notable lack of research on the later stages of AD, and it was heavily focused on the early to middle stages. And that actually was pretty general to all of the interventions that I found. They were heavily focused on the beginning and middle stages. And finally, with leisure, recreational satisfaction has been found to be a great predictor of quality of life in older adults. And some of the methods used in some of these studies included literature and crafts and even video games. But due to just the variety of leisure activities out there and just have differing personal interests, client-centeredness was really, really emphasized in the text. And there was some disagreement on the impact of recreation on quality of life, but however, the overall outcomes were generally positive, improving behaviors, engagement, and daily functioning. So when diving into the research, there were a variety of types of physical exercise that was out there for individuals with Alzheimer's. There wasn't really one that was deemed most beneficial for them. But some of the most common ones that they found were aerobic exercise, and ones I found were treadmill training, cycling on a stationary bike, just walking around their homes or on the track. Some strength and resistance training, whether that was with weights or TheraBands. Flexibility and balance training, saw quite a few research articles on yoga, and then also just some general stretching. And then just an overall comprehensive exercise program, which includes multiple components of each. Also, the research didn't really conclude to a specific type or intensity or frequency that was most beneficial. It varied from mild intensity, moderate intensity, high intensity, and then from 30 minutes to 60 minutes per session, and two times a week to 4 times a week. There wasn't really a huge consensus as long as there was some sort of physical exercise present. However, physical exercise does affect the brain as well. It impacts the beta amyloid protein production in the brain. So in Alzheimer's, a lot of it is correlated with the buildup of plaques and proteins in your brain, and it can reduce that production of the beta amyloid protein specifically, and most likely in the hippocampus, which can then impact memory, mood, cognition, and behavior in individuals with Alzheimer's. Some of the more significant benefits that they saw were improvements in short and long-term memory, improvements in social and object recognition memory, reduced symptoms of depression, reduced psychotic behaviors, reduced maladaptive behaviors, improved global cognition, and increased efficacy. However, there were some disputes among the research on this. And again, that was more of some systematic reviews really emphasized the importance of it on mood and memory and cognition. Some of the more pilot studies didn't really note any significant changes, and this is somewhere where further research could really dive into it. So the impact of exercise on individuals with and without Alzheimer's is pretty well documented. Noted improvements in balance and coordination, often seen if you perform yoga, mobility, whether that's with strength training, yoga, aerobic exercise, a lot of research supporting mobility with that. Yoga training also really helped with improvements in flexibility. Resistance training helped improve their strength. And then aerobic exercise was really important with improving their cardiorespiratory fitness. But why is that important for OTs? Why are memory, mood, and physical function important? Memory, cognition, and physical function are really impact how individuals perform their occupations. Some of the important aspects are that there are reduced risks of falls. Some studies noted that yoga and strength training were really important, reducing falls in the home, so keeping them in their homes for a lot longer. They can help maintain independence and daily activities, whether that's with maintaining their endurance to keep performing those daily activities, or them still having those executive functioning skills to perform those IADLs in their homes. It helped them maintain their quality of life, and it also reduced caregiver stress, which I found really, really fascinating. There was one study that conducted a focus group with both the individuals with Alzheimer's and their caregivers. And one of the big things that they noted is that due to that aerobic exercise program that they performed in that study, the individuals and the caregivers felt that they had that more independence, and they felt like the caregivers could leave them at home for longer periods of time, and they felt like their safety wasn't as much of a concern. So it really helped reduce the caregiver stress aspect of it as well.
Okay, so I'm going to talk a little bit about cognition in ADLs and self-awareness. So a pilot study with 21 participants was conducted to assess individuals with AD and the effects on home-based, high-intensity, and multi-component OT interventions on ADLs. These intervention sessions were 2 times a week for 90 minutes, including 5 minutes of space-time orientation, about 30 minutes of activities or tasks directed towards the main objective of each session, established according to the specific needs of each participant, about 30 minutes for ADL training, 10 minutes to relax, and 15 minutes for caregiver counseling. The Barthel Index and Lowenstein Occupational Therapy Cognitive Assessment for Geriatrics were used to assess participants' ADL independence and cognition on 4 different occasions over the course of 6.5 months. 14 participants improved their total score, increasing in the activities of dressing, bathing, grooming, and toileting, with statistically significant improvement for functional independence and dressing, while 7 of the participants remained unchanged. There was also statistically significant change in 4 of the subtests of GWAPTA, including place orientation, time orientation, reproduction of the puzzle, and attention and concentration. These results indicate that the intervention used through the pilot study was beneficial to the majority of the participants with mild to moderate AD. The ability to recognize deficits and cognitive impairment related to the disease process is especially important for individuals to conceptualize in the early stages of AD. A qualitative study was conducted by developing a semi-structured interview guide with 23 questions based on the assessment scale of psychosocial impact of the diagnosis of dementia. The interview was to assess specific domains of awareness in 34 individuals with mild to moderate stages of AD to understand our concept of awareness. These results were categorized into domains of awareness of the disease, including cognitive deficits and health conditions, biological and genetic, psychosocial, combined, emotional, social functioning, and relationships and changes in their ADLs. 76 of these individuals exhibited awareness of their cognitive deficits and health condition, while 18 denied awareness. 50% of participants did not believe there was a relationship between genetics and the condition, while 21 recognized it, and 29% were unable to answer. In regards to their emotional state, 65 participants indicated more sadness than before their diagnosis. 47% reported increased anxiety, and 44% described an increase in anger. 62% of participants denied change in their social relationships, and 15% considered their family members as friends. 62% of participants noticed changes in their ADLs, while 35% did not. The researchers noted that only 4 participants mentioned words such as disease or Alzheimer's, and only 1 participant disclosed that they actually had the disease. They also noted that even though many participants noticed changes in their routine and how the disease affected their life, they were unable to recognize the need for help with chores or hygiene tasks when it was clearly present within the participant sample. So as occupational therapy, we know we play a large role in all the interventions that we discussed today. And do you have any questions?